Thank you so very much, Manish, and the scientific committee for giving me the opportunity to speak something on SBRT in recurrent and metastatic prostatic cancer. So I have nothing to disclose relevant to this presentation. So over the next 15 odd minutes, what we'll be seeing is the basic concepts of the recurrence and oligomets. And I'll be speaking more on the evidence rather than the technique in this particular lecture for constraints of the time which is available. And it will be more directed to the synchronous, metachronous, oligoprogressive, and post-treatment, what are the patterns of progression. So there is something unique about prostate cancer biology, which all of us know, that it has a very low proportion of cycling cells. The doubling time in untreated prostate CA is almost 4 years, and the response following RT is very slow. As you can see already, Sridhar has alluded to it in one of the discussion we had earlier. So now that brings us in the disease continuum to a hypothetical situation where there is a state between a localized disease and a widespread systemic disease. And this is kind of limited with regards to the number and the destination organs. Now, this particular state is oligometastatic state, and it is very relevant in the clinical and the molecular characteristics. And it also provides us a big window of opportunity because we can cure the patients with some aggressive treatment. Now, this shuns the idea of unidirectional concept proposed by Halstead, and this is where the dynamic spatiotemporal concept comes into play, where the primary tumor can itself act to prime the pre-metastatic sites, and also the cancer cells from the metastatic sites go back to the primary tumor. And this is how the relationship is actually built up. Now that brings us to a point why the chance is very high when you're treating this, chance of cure is very high when you're treating this particular situation. Because the primary tumor, there are certain environmental conditions which forestalls the evolutionary clonal pressure. And more importantly, the slough cancer cells, they do not survive the circulation, and they may hopefully lodge in some inhospitable target organs. This is in stark contrast to the polymetastatic scenario. So the goals of our treatment should be to increase the cancer-specific survival, to increase the symptom-free survival, and also ultimately prolong the time until the systemic treatment. So it goes without saying that we need to capture the metastatic burden non-invasively, and PSMA scan is something which is more relevant in this particular context. Coming back to the definition of oligometastatic and recurrent scenarios, as you can see, usually it's less than 5. Location of the lesions are bone or bone, node, or soft tissue. And if you look into the trials, there is a different kind of definition in latitude and charted clinical trials. When it's usually categorized into high risk, when we are dealing with more than 3 bone mets and visceral mets, and as per charted, it's high volume. If more than 4 bone mets, at least 1 beyond the spine or pelvis and visceral mets. Nodal mets in charted clinical trial are categorized as low volume diseases. Now, this draws our attention to the EORTC classification, wherein genuine oligometastatic disease can be de novo, and it is categorized based on the duration from the diagnosis or primary diagnosis. If it is less than 6 months, it's typically synchronous, and more than 6 months, it's metachronous. And if it relapses in the post-treatment scenario, it's repeat recurrence or oligometastatic. So in the next 12 minutes, what we'll be discussing is in these 3 particular contexts. Metachronous oligomets, as you see, systemic therapy is the standard of care. As you can see right there is ample evidence which is available from the charted and the stampede and the latitude clinical trials. If you can see, low volume disease patients typically have a much better advantage with chemotherapy. But there is arm trial where radiation was incorporated, and the typical fractionation schedule which was used was 36 gray in 6 fractions or 55 in 20 fractions. And upon the subgroup analysis, the prostate radiotherapy actually improved the survival in the patients with low metastatic burden. The second important concept is metachronous oligomets. How do we get to deal with this? Now, this is a group which is mostly heterogeneous and where the primary is usually controlled. The evidence which we have here is typically the phase 2 randomized clinical trials, the SABRE trial, the STORM, and the ORIOLE trial. Now, we have several treatment options, as alluded by Karan earlier. Continued surveillance is one of the options, local therapy with or without ADT, SBRT to the involved node or the site, which is supported by the STORM and the ORIOLE data, and ENI with the dose escalation to the involved node is also one of the options which can be explored. If you look into the SABRE Comet trial, here typically less than 5 nodes, 5 lesions are kind of involved, and the life expectancy is beyond 6 months. Though the sample size was 97, there were only 16 prostate cancer patients in this particular clinical trial. And the latest updated results have shown that the metastatic directed therapy actually improved the overall survival. And this kind of continued at the end of 5th year as well. The STORM trial is again a randomized clinical trial between SBRT and surveillance in 62 patients for patients who are having less than 3 meds and testosterone more than 60 nanograms per ml. Again, in this updated analysis, you can see the 5-year androgen ADT-free survival was 8% for the survival arm, but 34% for the MDT group. So the same even with the ORIOLE trial, everywhere you can see there is an increase in the progression-free survival, the biochemical relapse-free survival, and name it, wherever RT was incorporated, it has shown benefit in overall survival and biochemical relapse-free survival. Having said that, you need to understand that this was a very good retrospective multi-institutional study which was done for patients who are having one node. Essentially, the elective nodal radiotherapy was better compared to SBRT, but more than one node. Essentially, there has been no difference between ENRT and SBRT. So obviously, we need to take a decision based on the PSMA scan findings. With this level 2 evidence, which we have prospective randomized controlled trials, there are several phase 3 ongoing clinical trials which are still recruiting and active, where we are trying to test the standard of care versus SBRT or SBRT plus surgery. The last one is an oligoprogressive stage. This evidence for this is typically retrospective. And again, as you see here, the patients who were selected were having either primary or less than 5 lesions right there, and several outcome measures which included the PSA failures, the time to next intervention period, the DMFS and all. Radiotherapy typically has shown a sustained periods of DFS, and it could probably add benefit in addition to systemic therapy. And similarly, a multi-centric trial and a progressive site-directed therapy in castrate-resistant prostate cancer. All this have together shown that there is an improvement in the disease-free survival. With these 3 approaches, let's understand the patterns of progression we see post SBRT. And typically, all the trials which I discussed were more into SBRT. So typically, we keep all these patients also on ADT following the SBRT. And you can see there was a very good trial which has been multicentric trial, which has been published by Teak et al. And you can see those patients who had MDT alone or MDT plus metastatic directed therapy in ADT. you have essentially categorized into three classes. Class 1 is long-term control, class 2 is oligoprogression, and class 3 is polyprogression. When MDT is incorporated, the long-term control has decreased from 41 to 27%. Oligoprogression has decreased from, has actually increased little. And polyprogression, there was not much difference. So the point which I'm trying to make here is the long-term local control has been very good for all those patients where ADT has been incorporated in addition to MDT. So to conclude my talk, because we need to understand that oligometastatic disease is a transition stage between local and systemic disease with unique MRI expression signatures. SBRT is typically safe as per the available evidence. For de novo, it is level 1, oligorecurrent, oligoprogressive, it is level 2 evidence. Thank you so very much for your patient listening.